DMD is a genetic disease that primarily affects males. It mainly manifests during early childhood and remains until the patients die during their early adulthood. As the disease progresses, patients will experience symptoms including but not limited to difficulty walking, loss of ability to walk, and issues in heart and lung that can eventually lead to death. DMD is caused by loss of dystrophin in muscle fibers, which is in turn caused by mutations in patient genomes that prevents the production of normal dystrophin protein. The loss of this protein will subsequently cause the loss of dystrophin glycoprotein complex and their associated proteins. This leads to a disjunction between extracellular matrix and muscle fiber cell membrane and defects in nitric oxide production due to a loss of neuronal nitric oxide synthase. These defects then cause an unstable membrane vulnerable to damage and insufficient blood supplies to muscles, which in turn leads to continuous degeneration of muscle fibers. At the end, the results are muscle weakness due to lack of functional contractile units and muscle stiffness due to muscle fibrosis. Many treatments have been and are being developed for DMD. Some treatments aim to restore membrane stability and dystrophin glycoprotein complex. Examples of these treatments include correcting of dystrophin gene using CRISPR system, addition of an incomplete but functional dystrophin gene to patient cells through episomes created by adeno-associated viral vectors, and reading frame restoration using exon skipping mediated by oligonucleotides. Other treatments aim to provide alleviation for the symptoms. Examples of these treatments include steroid treatments, medications that restore nitric oxide in muscles, and antifibrotic agents that downregulate production of collagen. This video will introduce the antifibrotic treatment approach of DMD. Scar tissue is formed when rapid repair is needed after traumatic damage or when repeated damage have caused an accumulation of collagen. In other words, scar forms when regeneration of tissue is required, but the sustained damage have exceeded the regenerative capability of functional tissues. The persistence of tissue injury also tends to lead to chronic inflammation and, most of the time, to the establishment of fibrosis that progressively replaces the parenchyma. Muscle is no exception. One of the symptoms for DMDs is continuous cycle of degeneration and regeneration of muscle fibers. This cycle can cause depletion of stem cells that are used for regeneration and disrupting in inflammation response that moderates the digestion of damaged fibers and regeneration of new fibers, both of which may lead to replacement of damaged fiber by extracellular matrix instead of new fibers, and accelerate the establishment of fibrosis. As a consequence, muscle loses its ability to stretch and contract and become stiff, which can be problematic if happens in limbs and life-threatening if happens in heart or diaphragm. DMD patients suffer from chronic muscle injury and their muscle fibers are undergoing continuous cycle of degeneration and regeneration. Muscle fibrosis can worsen their condition by stopping their muscle fibers from regeneration and further reducing muscle functionality. This also means muscle fibrosis can reduce the potential improvement brought by other therapies. Currently available therapies are not perfect. That is to say, they can only slow but not stop abnormal muscle degeneration. Fibrosis will still occur during this process of repeated injury and prevent regeneration of muscle cells. Even if a permanent cure for DMD emerges, it will still take time for patients to be diagnosed, their genomes analyzed, and their personalized gene therapy prepared. During this time, irreversible fibrosis would have already occurred. Regardless of whether patient is improved at genetic level, muscle condition improvement is limited without reducing fibrosis. That is, treatment improved muscle fiber condition will be less useful if there is less remaining muscle fibers. Although standard steroid treatments are shown to somewhat reduce muscle fibrosis, this effect has been insufficient, thus new treatments are needed to prevent fibrosis. There are two ways to reduce muscle fibrosis. One is to reduce the rate of scar tissue formation, the other is to promote removal of existing scar tissues. However, since extracellular matrix of normal and functional muscle tissue contain collagen, a major component of scar tissue as well, a treatment that causes the degradation of collagen may also cause the loss of essential collagen in muscle and other tissue as an undesired side effect. Physical removal of fibrotic tissue in DMD is also unlikely since fibrotic tissue is spread throughout patient muscles and sometimes within patient vital organs. Thus, most current treatments focus on prevention of muscle scar formation. Some treatments act directly on collagen-producing fibroblasts. Downregulation of collagen protein production using overexpressed collagen regulators delivered by AAV vectors have been shown to be effective in animal models if combined with microdystrophin treatment. Others act on signal pathways that can lead to deposition of collagen in tissue. Treatment with drugs such as a tyrosine kinase inhibitor that interferes with platelet-derived growth factor signaling pathway have been shown to decrease the expression of fibrotic gene in fibroblasts of treated DMD animals models and improve muscle condition. Another way of downregulating collagen production is to modify activity of macrophages, such as the activation of AMPK through use of metformin, which then leads to decreased latent TGF-beta-1 secretion. A decrease in TGF-beta signaling to fibroadipogenic progenitors can then lead to a decrease in rate of deposition of collagen. In summary, most of the antifibrotic treatment under development interferes with intra- and extracellular signaling pathways using fibroblasts as effectors in order to reduce collagen production. In the near future, this treatment may be combined to maximize effect and minimize side effects. Most of these antifibrotic treatments are shown to be effective when used on DMD animal models, and few antifibrotic agents have been used by humans as treatments specifically for DMD, but the prospects look promising. Although there are a lot of work left to be done, perhaps one day, through the combination of newborn genetic screening, antifibrotic agents, and genetic therapies and other treatments, we may stop DMD progression before disease manifests, recover the damage caused, and permanently stop the appearance of further disease symptoms. Thanks for watching.